Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which has a catchy title called How Not to Be Stupid. I don't know whether it's a statement or a question, but either way, Dr. Murali Thondebhavi will be, shedding some light on that. Dr. Murali is a consultant anesthesia and pain management at Apollo Hospitals, Bangalore. He did his MBBS from Bangalore University, MD anesthesiology from Rajiv Gandhi University of Health Sciences. He's a fellow of the Royal College of Anesthesiologists and also a fellow of the Faculty of Pain Medicine of Royal College of Anesthesiologists. To top this all, he has also done his MBA in Hospital Administration from ICFAI University. Dr. Murali has several publications to his credit and has written a book called Think Like an Anesthetist, and he's also contributed to book chapters. His special interests include information technology, and he has helped develop mobile apps, two of which are Iora for You and Zelsia, both for anesthesiologists. Dr. Murali is also an amateur photographer and is an avid blogger. His Worthy podcast series puts together interesting podcasts on various topics from around the globe. He's a regular faculty at regional and national conferences, and his talk on mental models in our Marvelous Medicine series was very much appreciated. Thank you, Dr. Murali Thondebhavi, for making time in your busy schedule to join us today on Marvelous Medicine.
Thank you, ma'am. Thanks a lot. In fact, such an august gathering, I will definitely, agree to any time whenever you invite me to speak on this platform. So good evening, ladies and gentlemen. I can see many familiar faces, especially a lot of senior professors and colleagues and teachers of mine. Good evening to one and all. So the topic this evening is something very different to what probably has been there on Marvelous Medicine before. And it has definitely kind of made people curious as to what this talk is all about. So I'll just get started. 1 second.
So while you get ready, Murali, a quick word about Dr. Krishna Kumar, who will be moderating the session. He's the clinical professor and head of pediatric cardiology at Amrita Institute of Medical Sciences, Kochi, where he established the pediatric heart program. Dr. Krishna Kumar did his MBBS from Maulana Azad Medical College, MD Internal Medicine, and DM Cardiology from All India Institute of Medical Sciences, Delhi. He also did his fellowship in pediatric cardiology from Children's Hospital, Harvard Medical School. He's a fellow of the American College of Cardiology and also of the American Heart Association. He has over 250 publications to his credit and has been the editor of various journals and textbooks. He's passionate about quality and safety and providing affordable cardiac care to children. He's part of a group that conducts master classes in cardiology, of which they have recently completed 50 episodes. Dr. Krishna Kumar has been a supporter of Marvelous Medicine, and he's always helped me out with topics, speakers, moderators, the works. So thank you, KK, for making the time today. Over to you, Dr. Murali.
Thank you, ma'am. Thanks a lot. So we'll get started with the topic of how not to be stupid. Now, the outline of my talk will be initially to define stupidity, because that is one of the main things that we need to do. And then we look at the various reasons or types of stupidity. We are looking at the system-related reasons and then individual reasons, and what is the way out. And finally, a little bit about why stupidity is extremely important when it comes to medicine. So we'll talk a little bit about what complex systems are and how does it affect them. So when we take the meaning of stupidity and we look at various dictionaries, we get these kind of meanings. So it is silly or unwise, showing poor judgment or little intelligence, annoying or causing a problem, having or showing a great lack of intelligence or common sense, given to unintelligent decisions or acts, or acting in an unintelligent or careless manner, or marked by or resulting from unreasoned thinking. But if you look at what stupidity actually is, now I chanced upon this gentleman, Adam Robinson, way back around 5-6 years ago. In fact, it happens to be his birthday today, because I just happened to read one of his blogs recently, and it happened to be his birthday today. He said that stupidity is not having or lack of intelligence. It is actually the cost of intelligence operating in a complex environment. And when we talk about complex environment, nothing can get more complex than a hospital and especially an operating theater. And it is almost inevitable that we will end up being stupid because we are working in such a complex environment. So he said it is the cost of intelligence operating in a complex environment and not the other dictionary meanings that we actually saw in the previous slide. And he also said that this stupidity is nothing but overlooking or dismissing conspicuously crucial information. So something right in front of us and we overlook or dismiss. Now, have you ever been stupid? Now, this is a question, I'm asking a lot of senior people, very well-read people here, and all of us have been. Whenever we've attended a magic show, right, from the time when we were kids or even when we were grown-ups, this is PC Sorkar, one of the famous magicians of India. Definitely, we have seen magicians pull the trick, and we felt very stupid that we didn't understand the trick. We've been kind of cheated, but again, we are paid there to kind of go and see this and enjoy ourselves. So we feel that yes, we have been stupid, but it's okay. So this is a benign kind of stupidity that we all have kind of faced. But can stupidity cost lives? Now, this seminal work, which came out in 1999 from the Institute of Medicine, actually set a tone for safety in healthcare. Now, what they concluded in this, it's a wonderful book, actually, it's available free online to download, that 44 to 98,000 people die each year as a result of preventable medical errors. This was in 1999. And it also asserted that the problem is not bad people in healthcare, but it's a good people who are working in bad systems that need to be made safer. Now, following this paper, a lot of research, a lot of articles came out with safety. So if you can see the graph here, there was a big uptake in the editorials, the letters, the reviews, which all spoke about safety. And again, news items. So there was a lot of interest in patient safety, in trying to improve the healthcare. But we fast forward to 2016 with this publication in BMJ, and they actually highlighted that the medical error was costing, by their estimate, around 250,000 lives. Now, this again made news, and it has been quoted by many people, many articles. I think it's got around 4,000 citations, if I'm not mistaken. And this became a widely known number that third most common cause of death in the US is due to medical error. And when I say medical error, these are errors which are caused by nurses, by doctors, by healthcare professionals because they overlooked something. So in other words, stupidity was rated as the third most common cause of death in the US. So what are the system errors that can, system reasons or system errors that can lead to stupidity? Now, if you look at rule-based stupidity, we can go back to the Romans. Romans came out with this mathematical system. Now, studying this as a kid when we were doing high school, we definitely felt that it was not probably the best mathematical system. But Romans did not see this because it was a rule-based stupidity that came into being. So the Romans could not advance themselves in mathematics. And because of the flawed system of numerals, they were unable to do complex maths. Same thing goes with solving a Rubik cube. Now, you can have a correct algorithm, a flawed algorithm, or a random attempt. Now, if it is a system-related issue, the flawed algorithm will never let you solve a Rubik's cube. You can, by random attempt, get the Rubik's cube right. Of course, you'll get it right with the correct algorithm, but with a flawed algorithm, you'll never get it right. So where do we see flawed algorithms? We see it everywhere. Political parties making mistakes, stock markets having issues, climate change, because we don't understand climate change or we don't act upon it. Anti-vaccine movements, we see it all around us. And organizations like Apple or say Infosys have good systems, good algorithms, and intelligence emerges out of that. Whereas if you see organizations like Enron, which went bankrupt, and even Reliance Communications, stupidity has emerged because of flawed systems. So we are looking at system errors which can cause stupidity. Now, what is the way out? One of the things, whenever you're faced with stupidity when it comes to systems, is to have an open disagreement, because this actually increases the collective intelligence of the group. And if there is more agreement in a group, less gets contributed to the general pool of ideas and arguments. Now, this has been highlighted very well by Ray Dalio in his book, and I would strongly recommend people who like books to probably go through this. And it's a wonderful book which has got a lot of good principles for life and otherwise. Coming to another important cause of system-based stupidity, it is something called as borderline tolerated conditions of use. Now, it might look very complicated, but we do this every day. To give you an example, let me take the anesthetic example. Now, in anesthesia, we do what we call as the anesthesia machine check. That is, we have to check the machine and make sure that there are no faults in the machine before we start an anesthetic. Now, if you see this graph, the green highlighted area is the area where we have set rules. And we have set some rules. Say, for example, the anesthesia machine check, we say, yes, before an anesthetic, we have to always check the machine. So that is a guideline which has been passed. And if we do it regularly, we are in what we call as the legal zone. That is, it's a safe zone where the patient is safe, we are safe, and it's a legal zone. Now, let's take, for example, we have a increased workload and we have been understaffed for some reason. We start kind of cutting corners. Now, we tell our technicians to do the anesthesia machine check, and the technicians are doing it once in a while. And we have reached an area, which is this yellow zone, which is illegal, but it is normal because now we have made a concession in our system that, yes, we can let the technicians check because we are busy, and these people are checking it, and it should be okay. So we have reached what we call as a borderline tolerated condition of use area. And then one day, what happens? The technicians have failed to check. I have failed to check. And then the machine stops working midway during the case, and it can cause a harm to the patient. And this area is what we call as an illegal area, where we have reached a stage where there's an incident which has happened. Now, the BTCUs are otherwise called violations, and violations can be accepted by the system because the management is there putting a pressure to increase the cases and bring in more revenue. So the management agrees to it, the department agrees to it. So we have reached a stage where we have created an illegal normal, which can anytime slip into an illegal place. So this we see all around us. To give you an example, better example, people not wearing helmets when they go to buy groceries nearby their house. So they say, fine, I'm just going to pick up something like milk or a few vegetables. I don't need a helmet. Now this becomes normal. It's illegal normal. And one day they end up with a road traffic accident and head injury, which again can be a disaster. So a BTCU is first seen as a benefit and not a risk. It enhances the performance initially of either the system or the individual, and it is tolerated by the senior management. And there is variety of informal safety measures which kind of get built in, which are not normal or which is not legal. And the solution here is incident reporting systems do not pick it up at all because they have not caused incidents yet. The BTCUs have not caused incidents. And we have to be attentive to this progressive drift. So it's a slippery slope. We have to be attentive to this progressive drift in practice, and there has to be a proactive control whenever we see this happening around us. And we have to set realistic goals amongst ourselves, discuss openly as a team, and then come out with solutions as to what is accepted and what is not. And if we see certain individuals who are more prone to violations, we have to identify them and we have to train them accordingly. So this is a stupidity which can occur because of a system error. Now coming to the most important thing, as an individual, what can I do? What are the reasons that can lead to stupidity? Now, pure stupidity. Now, this is somebody everybody will recognize if they've read a Tinkle comic. Fortunately, many doctors don't fall into this category. So this is Supandi. Coming to ignorant stupidity, which is a second type of stupidity that we can see at an individual level. If somebody is unable to retain information due to low IQ, or they lack education with basics which are missing, less they know, the harder it becomes for them to learn. Then less they learn, less they know, and stupider they get. So this is something which we see if people don't have their basics right, or if they're not keen on studying the first principles or basics. The second thing which we can see, which we commonly see, is what we call as fish out of water stupidity. This happens when we are outside what we call as a circle of competence. So all of us know that we can do certain things, we cannot do certain things. So what we know is in this green zone, which is the safety zone. What we think we know is the danger zone. And here is the biggest risk. And then the gray zone is everything else that we don't know. So I definitely don't know how to fly a plane, right? So that comes in the gray zone. But I might think I know how to do certain things. So to give you an example, somebody who is proficient in lumbar epidural thinks they can do a pain procedure, such as a cervical epidural or a cervical facet joint injection, just because they know something else which is very similar. Same thing goes with surgery. A general surgeon who has been operating, and a very experienced general surgeon, thinks that yes, they can kind of wing it a little bit and learn laparoscopic surgery by doing a weekend course and come and do laparoscopic procedures. The same thing happens as anesthetists when we are used to giving anesthesia in the operating room complex, but we think that doing the same thing in, say, a MRI or a CT room is the same. Now, this is where we need to be very careful, because the moment we step out of our routine environment, it could be just walking out of the door when I go into the road. It is a different environment. It is not my routine environment. And once I change this, I am prone to doing stupid things. So how to overcome this hurdle? First, we need to understand what our perimeter is when it comes to circle of competence. Very importantly, we need to slow down. We need to understand what our limitations are. We need to work to expand the circle so that we learn new things. And never fool yourself, especially in the beginning, because this is when mistakes happen. So just be careful when you're starting off something new that you don't fool yourself. And we have to read and intelligently read so that we learn from what we read, and we also learn from others' mistakes. The second factor that can lead to stupidity in an individual level is information overload. And I'm sure all of you will agree that in the last decade, we have had a tremendous explosion with the amount of information coming in. So let's take an example of an operating theater. Now, this is the typical monitor when we switch on all the parameters. So you can see a lot of things coming up in the screen. Now, I don't want to see so many things. Now, if somebody is there as an anesthetist who's probably seen this, they would have picked up that definitely the heart rate is not 200. But when you're seeing so many numbers, you might actually miss this. So whenever we have an information overload on the screen, we might miss something which is very obvious and very important. And you add a mobile phone in the operating theater, and it is a disaster, because you have, again, the monitor which is showing so many things and your mobile phone showing so many things, especially the one which shows here, which says stocks, right? So people who are doing this on a real-time basis will be having too much of information coming in. So this overload can lead to people acting stupid. So in regards to this, the Anesthesia Patient Safety Foundation, which is a body which looks at patient safety in the US, came out with a very important article in 2017 talking about distractions. And they said that they should implement what is called as a sterile cockpit time. So this is a time when during critical phases of the procedure, such as an induction of anesthesia or during extubation or during critical phases of the surgery, everything is silent. So these are like sterile periods where talking is avoided, music is avoided, and also phone calls and other things are avoided. So this is something which came out as a recommendation from the APSF in 2017. And coming to information overload, now we know that we are getting everything at our fingertips. I can read any journal, I can read any newspaper, I can read a lot of stuff just by opening my phone. So this is what is happening. The information available is going up in an exponential manner, but as a human being, the evolution has not yet caught up. We cannot consume more than probably something here, like the green line. And this is the gap that is widening day by day. And the same thing goes with medical articles, which are cataloged each year, and it is going up exponentially. So how do we manage so much of information? Now, one of the good papers which came out in 2016, they had a nice flow chart that whenever you're faced with new information and it is an incidental finding, if it is useful information, you store it so that you can retrieve it and cite it later. And if it's a new information which is obtained by intentional search, like say a PubMed search or a Google search, you can do the same thing. And we do have, like this is one of the apps that we have designed where we get RSS feeds which are directly from the journal so that you can actually look at the abstracts and then go into the detail if required. And you can subscribe to various RSS readers. So if you are subscribing to a few journals, then you can just select their RSS feed so that you get to know what is happening with regards to the journals, what is new in the journal. Now coming to how do we save this information? Now we have multiple apps for this. This is something called as Evernote. And we need to develop what is called as a second brain because we cannot store everything in our primary brain. So the concept of second brain is that we capture and keep what resonates with us. We organize it so that you save it for actionability later. You distill it once in a while to find the essence. And finally, you use it and express it and show your work. So this is a mnemonic called code, which you can all use. And where do you store this? Where can you store this? Now, I use an app called Notion, and many of you might be using it. And how I capture it is something like, so this is my Notion. So whenever I listen to a podcast, I make notes. When I read books, I make notes. Or if I come across interesting articles, I make notes. So this is something that is always there with me, either on my computer or my phone or my iPad. So I can access it. I can use it to actually, either write articles or discuss interesting concepts. So this is something that all of us can practice by building up a second brain so that we are not having an information overload at any time. So how to focus in the age of distraction? Now, this is a good mind map. And it talks about how we can kind of take the digital detox, manage our workspace, and how to work. And there are multiple techniques of using timers, the Pomodoro technique, which is working for 20 minutes, taking 5 minutes break, and creating rituals and habits, and taking time to reflect and review. So journaling is something that again can help in this regard. Now coming to another important factor which can lead to stupidity, this is stress. Now, what is stress? Now, all of us are doctors, and we know that a stress response is when we have a cortisol release due to various reasons. And if you look at the graph here, when the demands are in excess of the ability, that is when we start having all the signs of stress, such as reduced efficiency, to being anxious, to having finally a burnout. And one of the key factors in having stress is lack of sleep. Now, I cannot stress this more, especially as an anesthetist who puts people to sleep. But having read quite a lot about sleep, I think sleep is extremely important. Now, this is a book I would recommend for people who are interested to delve more into it. This is by Matthew Walker, and it's a book called Why We Sleep. And one of the research articles that he had published talks about how the positive, negative, or neutral stimulus, the response to that is dampened by lack of sleep. So we can see that this black graph here, the black bar, is low in each of this. So we don't respond to a positive stimulus well, we don't respond to a negative nor a neutral stimulus whenever we are sleep deprived. So when we talk about sleep, one of the main things that people talk about is sleep hygiene. It's a very vogue topic now. And sleep hygiene is extremely important, sleeping at the right time, avoiding all the gadgets around and having the right kind of environment. Then the other thing which is talked about quite a lot is sleep debt. Now, sleep debt is a concept wherein we end up sleeping less every day so that we have a sleep debt at the end of the week, and then we sleep excessively over the weekend. But this doesn't actually help stabilize the sleep cycle, and it is not something which is encouraged by experts in sleep. But the most important thing which is being stressed upon by fitness experts, sleep experts everywhere around the world is sleep consistency. So sleeping within half an hour to 45 minutes, plus or minus every day, and waking up plus or minus half an hour every day at the same time. So let's take example, we are sleeping at 10:30 every day and getting up between 5 and 5:30. So keeping this as a consistent sleep-wake cycle is most important when it comes to sleep hygiene and sleep physiology now. So what are the other things that can be done to de-stress? We all know this because we have been told, we tell others, we need to slow down. We need to keep calm. We need to be positive. We need to take it easy. Now, it's easy to say, but ourselves, it's very difficult to do it. One of the very important things which I would stress here is meditation. And meditation is taking up in a very big way across the world, especially for people who want to perform better. And meditation has, it's very easy, especially being in a country like India. We can enroll ourselves in meditation courses, or if you find it easy, you can even download good apps which are available for meditation. And it needn't have to be only for 20 minutes or 30 minutes. You need to kind of build meditation into your full routine. So if you're even standing there waiting for a lift, you should be aware that you're breathing. You should be taking nice deep breaths. So these kind of things have to be done when we have to de-stress. And finally, another important aspect is work-life balance, which helps in de-stressing. So the 5 things which are important for a work-life balance is work, health, relationships, especially with our closed ones, spirit, which is a connect within ourselves, and finally our interest or hobbies. And just like how you see a juggler juggling 5 balls, the main thing here is that we only can control 2 balls at a time, which we are able to throw, and the remaining 3 are in the air. So if we apply the same concept here, we can connect 2 of our 5 spheres here, and that can be used together to de-stress. So for example, work and health can be combined by either walking to work or parking the car a little bit further away and walking to work. Work and interest can be combined in a different way. Relationship and health can be combined by going for a walk or doing something together with your partner or spouse. So this is something that we can incorporate to decrease the stress. Now, coming to another important factor which can lead to stupidity is fixation on an outcome. Now, this is a photograph from May 2019, when there was a huge rush on the Mount Everest final climb, and many people lost their lives. And this was something which was caused because they were fixated on the outcome of reaching the summit. And this is a very tragic story which happened in the UK in 2000s. And this lady, Emily Bromley, was to undergo a very minor ENT procedure. And her husband actually is a pilot with the British Airways. And it so happened that 3 consultant anesthetists were fixated on intubating this lady when they could have just held their airway open and oxygenated her. Because these anesthetists were fixated on intubating, they led her to become hypoxic. She ended up with hypoxic brain injury and later died. And it all happened because they were not sticking to an algorithm which actually was there right there in front of them, and they were fixated on the outcome. The other thing which can cause stupidity is being in a group where social cohesion comes into play. Now, what does this mean? Now, social cohesion is willingness of members of a society to cooperate with each other in order to survive and prosper. Now, to give you an example, this is something which happened with me. So this is somebody known to me who called me in the morning as I was inducing a patient that they had upper back pain. Now, this patient was having such severe back pain, upper back pain, that when he came into the emergency, the initial thinking was that the patient was having an aortic aneurysm dissection, because even I thought so, and it was conveyed to the ER team, and the ER team also agreed with me. And the ER team is ready for this patient because they're thinking it's aortic dissection. Now, the ECG was done, but it wasn't seen because they are thinking that he needs a CT, because now the diagnosis is that it is aortic dissection. Now, when he was shifted into the CT, he actually had a cardiac arrest, and junior doctor, massive MI. So this was something where social cohesion played a role in making us feel stupid. And it was something which was very costly. So similar incidents might have happened in your life, in your careers, and I'm sure this is something that we have all learned from. Being in the presence of an authority is another factor which can make us become stupid. Now, what does it mean? Now, every flight has got a pilot and a co-pilot. So the person who is flying is the captain, and then there's a co-pilot. This incident happened way back in 2003 when the first officer who was sitting next did not detect that the aircraft was at an extreme roll and pitch attitude, or having identified the abnormal attitude was inhibited from bringing this to the attention of the commander, because the commander is superior and he couldn't voice his opinion there. And because there was a marked difference in age and experience between the commander and the first officer, this communication did not happen, and there was this accident. And there are multiple of these kind of accidents, especially which have been investigated in the airline industry and also in the medical profession, wherein a senior and the presence of a senior colleague inhibits the junior to voice his opinion when things are going wrong. And this again is something which we see because wisdom is knowledge and experience. And we think that somebody who is in the later part of the career is very knowledgeable, and we fail to question it. And the last most important catalyst for causing any kind of stupid decisions or stupid outcomes is rushing or urgency. Now, why do we rush? Now, it's a human nature to want to get a job done quickly, and we grew up being told to accomplish as much as we can. So the more time to do other things that might be enjoyable, because if we do things quickly and we do everything fast, then we'll have more time to do other things enjoyable. So we tend to rush. And rushing is something which is highlighted in every industry. So as you can see here, whether it is airline industry or whether it is any other industry, rushing is something which is known to cause mistakes. And Atul Gawande, whom I'm sure everybody is familiar with, came out with the checklist manifesto mainly to highlight this problem, that in the operating room, in the hospitals, we are rushing, we are causing mistakes. And once the book came out, it was a bestseller. And not only was it a bestseller, it actually led to the formation of the surgical safety checklist, which we all use now. And this has led to a lot of lives being saved and a lot of wrong surgeries being performed. Now, can we use checklists everywhere? Now, packing checklist is something that is available. Many of us probably use it whenever we are going on a holiday, because we have had instances where we have left behind things, even to the extent of leaving behind important documents like passports. So having a checklist will definitely make us look less stupid and make us do less stupid things. Another important checklist, which I'm sure many of us follow, is while getting out of a taxi, right? Because we have left something either in an auto rickshaw or a taxi sometime in our life. And we go through a mental checklist, because now we are checking all the things that we have taken inside, and then we're coming out because we have been through a situation where we have ended up being stupid. So checklist is another important thing that will avoid making mistakes, and especially when we're rushing. So these are the main factors. Now, why is stupidity important when it comes to medicine? Now, we saw initially that the medical errors have caused quite a lot of deaths. And here, we need to talk about something called as which are acting at the same time, which can lead to various different outcomes. So to give you an example, this is something called as a butterfly effect, wherein the weather systems can be affected by the flutter of a butterfly wing across the world. Of course, we have aviation, which has been very well. Human physiology, again, is a very complex system. Now, complex systems have few good things. That is, the whole is greater than the sum of the parts. So sum of the parts, various things working, and as we know, human body functioning really well, despite having a lot of different organs functioning in their own way. The second important good thing about a complex system is adaptability. And as human beings, we know we are very much adaptable. And as doctors, we know how patients respond when actually they are getting better. Coming to the drawbacks of complex systems, there can be something called as an emergence phenomena. That is, we can have surprises. Things might go completely haywire. And this is something which might not have a linear relationship, because then the system will behave in a completely different manner. And when this happens, the critical transitions can lead to breakdown of the system. So medicine is more complex than any other system we know out of the complex systems, because the way we measure complexity is by the ease of building computer simulation. So to take an example, if I say y equals x plus z, it can be plotted on a graph because there are 3 variables and it's easy. Aviation, again, has built extremely complex simulation systems based on algorithms, but we are still far away when it comes to understanding physiology and pathophysiology in the context of diseases. And at the same time, I would like to introduce a very important concept called the L time. Now, L time is something which is a mathematical concept based on the mathematician from Russia, Lyapunov. And this is a mathematical concept of complex systems. It is defined as a period of time before the system starts exhibiting chaotic behavior. Now, why is this important for us in this talk? If you take a galaxy or a Milky Way, it is very stable for millions of years. We can predict it because we know what is happening with gravity. We know where it is expanding, how the nebulae are kind of changing over to stars, and what's happening with supernova. When it comes to weather systems, of course, we can predict for a few days very accurately, but after 15 days to 1 month, the prediction becomes quite erratic. So the L time for weather is probably days. When it comes to the human body, the L time, that is the time in which it can degrade or it can kind of start exhibiting chaotic behavior, should be actually 50, 60, 70 years if everything goes in the clockwork manner, but it doesn't. When we are actually affected by disease, like example, simple thing like flu, like I was down with flu last week. My system was having a very low L time at that point because it had started behaving in a chaotic manner. I had myalgia, I had high grade fever. So it actually, the L time actually decreased just because I had infection. And one of the things iatrogenically that we do to decrease L time is giving anesthesia. When we give anesthesia, we are playing with the physiology of the patient by the drugs that we give, and we are decreasing this L time. The L time is the period of time which is taken for a complex system to exhibit chaotic behavior. And all anesthetists who have logged in here will understand that whenever we have given drugs to patients who are actually stable, many of them might have exhibited chaotic behavior in terms of being hypotensive or arrhythmias, and something which we couldn't predict. So whenever we have a system where the L time is low, being stupid can be very costly. Now, I wanted to highlight that by bringing this concept of complex system, because stupidity can be very expensive when we are dealing with complex systems with very small L time. So coming back to this paper, now, does this really actually is the number really true? 250,000 people dying. I looked at few other papers following this, and the predicted mortality, preventable mortality, was not that high. Now, this was a paper by Rodwin et al., which came out in 2020, and they looked at the case sheets. They studied the case files of people who had died, and they came out with a pooled rate of preventable mortality, which was 3.1%. And not everything is so gloomy. We are not kind of causing so many deaths. If you look at this graph, this is the decreasing mortality with anesthesia, and it's a logarithmic scale. So if you can see from 1947 to 2007, the number of deaths due to anesthetic, that is the perioperative deaths, are actually decreasing. And this paper again from in BMJ in 2015 shows that the avoidability, the preventable deaths, is around just 3.6%. So we are not looking at such high numbers. If we look at actually the real data, we actually are looking at in the range of 3 to 5%. And always we should look at what good things we are doing. Now we have been discussing about stupidity and how doctors are causing so many errors. But if you look at this tragedy that occurred in January this year, the Japanese airlines having a crash, there was so much of positive things that came out, how this crew handled the entire thing, how so many passengers were evacuated without even one death. So similarly, I think as doctors, we do a lot every day to save lives. We take on patients who have very high risk, who have been extremely unwell, and we treat them and send them home. And I think we need to be kinder to ourselves. We need to kind of highlight the good things that we do to the world, especially when it comes to the outcomes that we achieve. So to summarize my talk, know that there are few factors which can cause stupidity. One is being outside the circle of competence or being outside the normal routine environment. Stress is something which we can all avoid if possible, and this can decrease the errors. Rushing or urgency is the catalyst for most of it, and sitting still for a minute before we do something when we are rushing actually might be the solution. Fixation on an outcome is something, again, we should avoid. Information overload is something that we can manage well. And being in a group where cohesion thinking comes into play is where we have to be a little bit careful when these things are happening. And of course, being in the presence of an authority. We need to be able to speak up. We need to be able to tell when things are going wrong. And another important thing is having an observer. So have a friend whom you can kind of, in your life or at workplace, somebody who is just there to observe you. And if you're doing something wrong, they should have the openness to tell you that they're doing wrong. So this is somebody who can be called as a wingman. A wingman is somebody who is there in a fighter aircraft to make sure that the pilot is flying the plane correctly. And finally, understand that we are working in a complex system which can have an L time, which can be very short, and making any error can have real deleterious consequences. So this is the final slide of my talk, wherein Calvin and Hobbes are discussing as to what a stupid world that we are living in. Thank you.
Over to you, Dr. Krishna Kumar.
Brilliant, of course, Murali. I think
Thank you.
Really touched upon every dimension of stupidity, for lack of a better word. And what you've really done is you've listed you've sort of broken it down into so many elements that can go wrong in our hospital environment, but I guess in life as well. But there's a common thread, if you just look deeply, because we haven't sat through your lectures, and perhaps most of us have got a lot of what we're doing in our lives right. A few of us have made mistakes, and all of us have done that. But essentially, we function largely without too much stupidity. So there's a common thread I just wanted to say, which runs right through all those points that you listed out on focusing on an action, not the outcome as such, staying away from distraction, working within your circle of competence, getting enough sleep consistently, meditating, having a work-life balance. All those elements have one single common thread that go through it. And that's called mindfulness. I think if you're really aware of what you're doing at all points, it amounts to being successful in all dimensions of what we do. For those of you who are interested in cricket, there is a very, there's an unsung hero in cricket. It's not Rahul Dravid. It's a guy called Justin Langer, who was a very average in terms of just skill and talent, was just average. But what was brilliant about him was his ability to focus. He brought this very well on focusing on one ball at a time. So that seems to be the common thread that you need to sort of adapt at all points. I think I've kind of reflected on my own work in the cath lab, and essentially being mindful means just knowing about that one thing that you're doing at that time seems to be the common thread. You can correct me if you want to, change what I have to say. And then there's one more point that I wanted to bring about is it's really instructional what you have said, but isn't it hard to get most people to change based on what you have said? I mean, I would love to see a world where everybody changes and adopts, and including myself, adopt what you said. But these are habits, right? How do we make these habits change? And how do we, bring about that? And that has to be coming from every individual. So that's the real hard part for the individual. And of course, for collectively, because there's so much collective stupidity around us, that to change is really, really hard. So these are the challenges that we are confronted with. With that, I'll leave it open to everybody for questions. Murali, if you want to respond.
Thanks a lot for highlighting important points there. And as you said, mindfulness is probably the common thread. I agree. But to achieve mindfulness and being present in the now is probably the most difficult thing, especially with the kind of thoughts that keep going around and, the thinking about the past and the future. I'm sure everybody will agree that being mindful, being present in the now is probably the most challenging thing. And if we can achieve that, and I'm sure if we can achieve that, it will be the best thing because it will solve most of the problems. The second point which you highlighted is how do we get everybody to kind of start doing this? Now, I feel if we are able to sort out a few important things, especially things like sleep. Now, sleep is something which all of us are actually probably not getting enough of, and we don't know the consequences of not sleeping well. But if you look at athletes, you look at the elite trainers now, the importance that they're giving to sleep is very high. And as doctors, we probably neglect. There are people who are doing outpatients till 1 o'clock in the night, 12 o'clock in the night, and then coming back again at 5 o'clock. Now, definitely the cognitive dysfunction with such lack of sleep is very high. So I feel starting with something basic that we all know as doctors we should be doing is probably the first thing in eliminating a lot of mistakes that can happen. And of course, as we grow in our career, we realize that we have done mistakes in the past and we correct it and we come out with solutions for it. So I feel it is a part of a career growth where we pick up wisdom as we go.
There aren't that many questions in the chat box. Basically, everyone has appreciated your talk, and Dr. Rangaraj wanted to sort of clarify that wingman is actually in another plane looking for the primary pilot on the mission, and that's what probably you suggested, having someone else look at what you're doing.
Yeah.
So I think in the OT, I think many times we could be the anesthesiologist could be the wingman for the surgeon, and vice versa. Even if you cannot have another colleague of the same specialty. And I hope those of you who have seen the message from Dr. Krishna Kumar about 2 other books that you could read. Dr. Babji, did you want to say something? Your camera's on. You're muted, sir. Dr. Babji, you're muted. Yeah. You're muted, sir. Yeah.
Yeah. Actually, I was opening my video is on throughout. I didn't want to say anything, but as I was hearing, it's a wonderful thing. Anything mindfully done is highlighted very well. And if we are all mindful, definitely our stupidity comes down.
Thank you, sir. Radha, you have your camera on. Did you want to say something?
Wonderful presentation, and I agree with all of it. In 1999, when I first had gone to the Mass General Hospital, is when they published that to err is human, from the folks who are interested in safety, patient safety. That was like not very well spoken about at the time, but currently that seems to be the key word for everything. This is safe, this is safe. What about patient safety? Safety first. So after having thought about safety in all aspects of hospital practice, now I've started using those same principles at home too. And I don't let my mom come down the stairs talking, because I'm like, focus on what you're doing. Be mindful of your coming down, and talk later after you come down. So every little aspect in life seems to be, it's encroached into every little aspect of my life after thinking of patient safety at work. So highlighting that is an excellent way of presenting your talk, Dr. Thondebhavi. And also mindfulness is another thing. I'm trying to practice that even when I'm eating, when I'm driving. Some days I just drive to work not having known, really, did I really come to the garage already? So practicing mindfulness in everything is also important. And I started doing Sudarshan Kriya Yoga and meditation, and I am now focusing more on my sleep, because that seems to have helped too. So I agree with every little thing that you've been talking about, and it's a wonderful, wonderful presentation. And then timeout has become a huge part of our practice now. We do a timeout as soon as we enter the operating room. We do a surgical timeout right before, incision. Not that things are going to change too much at that point in time, but still. And then they also now do a debriefing. So surgeon does a debriefing before he leaves the operating room while his assistants are closing. So every little aspect is being done mindfully. And then there is also something called stop the line. So nobody is scared of saying anything anymore if something is not correct. In the past, I was just reading this. They were talking about how to incorporate all this. I just finished reading a book called The Power of Habit by Charles Duhigg. And that talks about a lot of these aspects, how to change the habit. So first of all, individual habit, and then you believe in yourself that you can change it. And then you start a small group, and then it kind of, from then on, it it's like a rolling ball. So it happens. So thanks, Vidya, for this amazing talk that you put together, and this was excellent. Thank you.
Thank you.
Dr. Manjunath, you have your camera on. Did you want to say something?
Hi, good evening all. I'm a pharmacologist from Pondicherry. I was, thank you, sir, for that wonderful talk. I was listening to that medication error part. I think everything is similar, the way things go wrong. It's called as, Swiss cheese effect, if I believe, when everything aligns. And actually, that is when the harm reaches the patient. Actually, one of the paradoxical thing is like, the stupidity does cost the patient, but at the same time, in medication error system, they say the system should be non-punitive, where an environment is created where the person who has committed a mistake, for example, nurse has given a wrong drug or to the wrong patient, she should have that environment where she can report so that next time it is prevented. Because as the document which was displayed itself shows that to err is human. I think that's so. I think that is not very vocally people. It is not a punishable thing, and it is something which we can talk about and correct it in the future. So those are my comments. Thank you, ma'am.
Dr. Bani, you want to say something?
Murli, I really enjoyed the talk.
Thank you, ma'am. Thank you.
Very nice. And my son is 38 years old, and his colleague had given him this book, Ray Dalio, Principles by Ray Dalio.
Yeah. So it's a very good book, actually.
My son didn't read it, but I read it. And then I send the notes. I write notes on my phone. Many things what you said, I do. So I send the notes to him and his friend who gave the book. Because we don't read the book in 1 week, then nobody reads it. But it was an excellent book. And I really believe in meaningful relationships. And many things he had told. And I'm not very careful at home. I leave the gas on and I forget to put it off. And being married to an anesthetist and a very careful anesthetist at that. So many things you said, like the technician checking the machine. And Ram had given, my husband, Ram Kumar had given a talk. Ravi Shankar had called him long ago, I think for Chakravarti Memorial oration on safety. And that's when I went with him and listened to the talk. And my favorite 4, and then Ram started Simulation Center. So thanks to Ram, actually, I learned to be safe, living with him for 40 odd years. And I always follow this. I learned from simulation that, you can tell somebody else, the senior does not have to be the team leader. And the 4 things I really love are briefing, debriefing, checklist, and closed loop communication. Because very often closed loop communication does not help. And you must have read about that McBroom, some similar story like you said about the pilot. So I always remember Dr. Tota, who was an excellent anesthetist and was fantastic. But everybody was scared of Funny. So whenever I hear that story, I think of Funny. Because he was so good and he was so clever that we were scared of him. So I'm remembering Funny today. I always do. I always remember Dr. Ravi Shankar, who's my husband's mentor. And I want to say thank you, Murli. I enjoyed the talk. Thank you.
Thank you, ma'am. Thank you. Thank you, ma'am. Thank you.
Dr. Amaravani, you have your hand up. Did you want to say something?
Yes, ma'am. Sir, thank you very much for an excellent talk. You covered everything. There are no doubts left unattended. I just wanted to add 2 points. What you are telling about this Henrich's pyramid that in a triangle, where there are 300 of near misses and which result in 29 minor injuries and which leads to 1 death. To overcome this, we have quality controls in the hospital where incident reporting is done and we take care of each incident so that we prevent the major injuries happening. Second thing is under stressful conditions, there is a 4D matrix. Do, delegate, defer, and delete. If you follow this, I think we can, you can control the stressful atmosphere. That's all, sir. Thank you very much.
Thank you. Thanks a lot. Thank you.
Dr. Ajay Sharma, you have your hand up?
Yeah, Dr. Murali, it was wonderful to listen to you. Hello.
Thanks, sir. Thank you.
I really enjoyed listening to it's very exemplary. So I've got only very 2 short comment. One is, what do you think is the role of regular morbidity and mortality meeting, which should be a routine in all the departments, not just academic departments? Number 2, central data collection of all the patients in India, which should not be costly at all. Well, it would require some cost, but the gains would be massive. Really, that would help us to really keep learning from our own errors. So what is your comment on that?
So, yes, sir, I do agree with regards to mortality, morbidity meetings. I'm sure most of the educational institutions have a framework of doing it, and even bigger corporate hospitals. But when it comes to smaller nursing homes or smaller centers, it definitely is not existent right now. Coming to the data collection, we started this app which Dr. Vidya mentioned earlier called Zelsia in 2016, where we started capturing critical incidents in anesthesia across India. And due to some other logistic issues, we had to put the app on the back burner. But right now, in January, we actually have launched the Anesthesia Patient Safety Forum in India. This was launched in Coimbatore, and we are presently working on an app wherein we'll be collecting anonymous critical incidents from across India, where we'll have a team of experts, around 60 experts who are the top experts in the field, who will put out learning points based on these critical incidents. Now, the main drawback or the hurdle that we face is people will not report critical incidents because of one, that there might be some kind of a punitive action, as the other gentleman was mentioning. But if we make it anonymous and we bring out learning from these incidents, I'm sure it will take up, and we are hoping that in the next year or so, we will increase the number of incidents which are reported. Ramkumar sir, you have.
Yeah. Again, echoing what my wife said, Murali, excellent talk. And
thank you, sir. Thank you.
Listening to it, I was just, recollecting my past 4 decades as an anesthesiologist. Many things that you said. Now there is, I was fortunate that I studied in JIPMA and I worked in Manipal, and both institutions had a way of looking at mistakes happening within the department. And I think that's very important. You mentioned it, but I think we need to really emphasize that, we don't really need to make all the mistakes ourselves to learn what can go wrong. That's the most stupid way of learning things. And you'll have to live probably 3 or 4 lives to make all those mistakes. So I think learning from somebody else's mistake is the best thing to do. And I think the only way to do that is to have an audit, a department inquiry, whatever. I mean, you just look at it in an informal way also. There's a lot of information that comes out of it. And I just wanted to emphasize that point, that the older we are, the more stupid things we have done. And I think it's always, that's why we become wiser, I think. By being more and more stupid over the years, we become wiser. And our checklist becomes longer and longer. That's why I think when a senior person starts operating or giving anesthesia, they take much longer to get the process started because they're going through so many inbuilt checklists in their mind, not necessarily what is recommended, like you were talking about, that because we've faced so many complications in our life. And that's what makes us less and less stupid as we practice medicine. Thank you. Lovely talk. Thank you.
Thank you, sir. In fact, on the same lines, the airline industry has got a book wherein all the mistakes that they have ever happened in airline industry across the world is written into that. And in fact, they talk about it as a book which is written in blood, because people have lost their lives by the mistakes that they have done, and those are the things that are learning points for the future generation. So I think similarly in medicine, if we start having collective wisdom coming into one place, then I think a lot of things will change.
Dr. Venkatesh Natarajan, you had a long message on the chat box. Would you like to just, put it in a question format to the speaker or moderator?
Yes, ma'am. Yes, ma'am. Excellent talk, sir. Brilliant talk about safety, complexities of what we do and how we learn from our own mistakes. But sometimes, we tend to live within certain rules, and our preoccupation with safety becomes more. But we all have to improvise, especially when we are working within resource-limited environments. And medicine being a science of extreme uncertainty, sometimes decisions have to be made where nobody is there to guide you. There is no new knowledge. So if new knowledge has to grow, one has to do some kind of daring. How would you view this within the context of patient safety?
Yes, sir. Now, when I mentioned that borderline tolerated conditions of use, that is an area where we have improvised. So we have started in an area where we had clear-cut guidelines or clear-cut knowledge, and because either we had to improvise because of resource limitation or the situation kind of warranting improvisation, we have improvised. Now, if we have improvised and done something new, I think we need to sit down with our team or with ourselves if we are alone and normalize it in a way that it becomes the normal going forward. So it could be, publishing a new technique. So we have done something different based on the situation that was given to us, and something new has come out. So this can be published and can be given as a source of knowledge to everybody else, and they can normalize it. So I feel safety is probably something which we can talk about very confidently when we have guidelines, when we have protocols, when we have a solid knowledge base that we can stand on. But when it comes to, as you said, newer conditions where we are still learning, because medicine is still a lot of learning going on, and I do chronic pain, and we still don't understand a lot about pain. So when we do certain procedures, we are of course not in the real safe zone, but we are in this borderline tolerated condition. So that's why it's called tolerated condition. So we tolerate that we are doing something different, which is outside of the complete safety.
Thank you. One more question, sir, if I'm permitted to ask.
Yes, please.
When it comes to documenting our mistakes, it becomes in a litigation-prone society, it can be a kind of double-edged weapon. And how would you view this? Because I find, apart from doctors, the judicial system and things outside the judicial system, the public view, they don't tend to look at medicine as a science of uncertainty. They tend to look at us as something as an absolute science, and errors, if you are admitting your errors, then you're opening a Pandora's box of accusations, and things can come out of it. And in that kind of a scenario, what do you recommend?
Now, one thing which definitely we are not doing is probably not having a frank discussion about risk with the patient. Patients bring in a lot of risk. Now, if I see a patient who has got multiple comorbidities coming in for a hip surgery, there is a risk exchange that takes place. That is, I am at a low risk, this patient is at a high risk. The moment I agree to give anesthesia to this patient, I have exchanged that risk, I have taken that risk onto myself. Now, if we don't discuss this risk openly in the society, and we keep telling patients that everything will be all right, yes, it's a minor procedure, nothing will go wrong, and the patient then ends up with a problem, that is when the expectations of the patient and the outcome that has happened doesn't match. So whenever in life we don't have an expectation matching the outcome, we are unhappy. It could be, the food that we are eating, or a holiday that we're going to, or a visit to the hospital, because the expectations that the patient comes in has not been matched because the outcome has not been great. So I think discussing risk should be something which we should all take seriously, and we should not shy away from discussing risk, because that is the way forward. And in that context, if something does happen, I think, again, documentation plays a vital role, because I'm sure experts here who are medico-legal experts will agree that without documentation, nothing will stand any water in the court. So I think documentation is important, but at the same time, documenting the discussion of risk, the consent, and later outcome is probably most important. And I would like to hear if anybody else has to say anything, because there are so many senior people here.
Now, I just want to rephrase that question again. Probably KK, you can take it. What Venkatesh is trying to say is, if I want to be upfront and say, yes, an error was committed, we're not talking, how do I, in a litigious society or in a place where you can get beaten up or whatever, how do you do that? Whether it is in the case sheet or whether it is to tell the patient or whatever, how does one actually, come forth and say, yes, it may not even have, may or may not have led to death or any serious thing, but just to say that an error was made, how do we do that in India today, in the, say, private or public sector, whatever?
Are you asking me, Dr. Vidya?
Yeah. I mean,
it's a tough one, actually. We don't have good ways of acknowledging our errors, both amongst ourselves and with the patients. I think with the patients, it's only possible to do so if you're having a tremendous level of trust and a rapport that you're sure that the patient will understand. When you acknowledge, of course, the way you communicate that whole process also has to be done in a way that the patient does not get aggravated or the patient's party does not get aggravated. It's very specific to that situation that you encounter where you can talk about it, but it needs to be done with a lot of finesse and subtlety. At the same time, you should be honest about it. It's a very difficult thing. And in this situation, what we found is that we seek the help of an experienced person. I'm just giving you an example. In our hospital, we have some exceptional communicators. When you have a situation that can be potentially litigious and very serious, we often consult them as to how best should we communicate this process to the patient. And often, like when you have a situation where the patient is being taken care of by multiple caregivers, we identify that caregiver that has the best rapport with the patient to actually talk about it. So that's sort of the ways we handle it. But actually, to be honest, I don't think I have a very good answer to that question, really, in terms of all of us will be cornered when we have that kind of a situation where we have to actually confess our errors.
So, Dr. Venkatesh, it doesn't look like we're going to get a straight answer to your question.
Yes.
Yeah. So, if anyone else can, share their experience or have some advice regarding this, please feel free, especially in the Indian context.
So Vidya, I'm sorry, I can't speak for the Indian context, but at least in the West, studies say that even if the surgeon is not very competent, if there's a mistake, if they go talk to the patient's families about what happened, and if they keep the communication lines open, the risk for litigation is much less. The same thing goes with anesthesia as well. So usually when there's a complication in the operating room, the anesthesiologist and the surgeon, we go together as a team and talk to the patient's family. And then we express empathy and we say, but most of the time, at least in my hospital, patients come as a last resort. So it could be different in other places. And I can't speak for the Indian context, but all studies also say that even if the surgeon is not, like in comparison with a very good surgeon and a moderately competent surgeon, the moderately competent surgeon, if his communication skills are good, he is less liable for litigation than a very good surgeon who is not very communicative. And at the same time, we also have patient advocacy, legal, so lots of people get into the system, social workers. So it's a big team effort when we have complications and we go talk to the patient. So that's the US context. So I can't speak for the Indian context though, because things were very different when I left there.
No, I think it's the same.
Adverse outcome is one thing, but acknowledgement of error, I mean, that's where the catch is. So KK, sorry to have interrupted.
Sorry, I meant to say that those principles apply here as well. There's no question. The exact human nature is the same everywhere. I've worked both in the US and in India, and communication is the essence. But then there has to be finesse in that communication. There has to be a recognition of the patient's condition. There has to be empathy expressed. And each situation has a different way of doing it. We do sometimes go as a team as well in India, but sometimes we need to do it differently, recognizing the specifics of the individual families. Sometimes we need to have them talk to one person whom they trust, with whom the rapport is superb. So we have to individualize that situation depending on our understanding of the patient's family's mindset. That dictates how we respond. So we have to really tailor our responses to that situation. And yes, there are no one rules for all this. It takes a very good understanding, a deep understanding of the patient's background and knowledge of their whole situation, social situation, then we try to tailor our response accordingly. But it's a tough one.
Let me give you a context, and probably that will add more to the discussion. There was one patient who actually was catheterized and he was being shifted from the OT to the wards. So now what happened during the time of transport is the catheter bag got caught in the wheel and he got pulled away and he sustained urethral injury and started bleeding. Now this patient was an absolutely simple surgery, and this was an error, and which nobody could foresee that something like that would happen. And he was shifted to the wards. The moment they were seeing blood, the instant question the attendants started asking is, what really happened? Why is he bleeding? Now, what kind of finesse, what kind of communication, giving the degree of risk tolerance of our patients, the threshold for our patients to judge us is probably more in an accusatory tone than to acknowledge that these things happen. I mean, after all, life happens. And we can later on fix it in the sense that we learn from it and we fix it. Something like that won't happen in the future. But if you want to kind of handle this kind of situation, how do you go about it? And that is the kind of question that I'm kind of interested in.
Yeah. So we have senior clinicians like Dr. Pandian Natarajan, Dr. Ramesh, Dr. Ravi Kannan. Any of you would like to bail us out on this sticky about this difficult situation?
Thank you, Vidya, to not put me on the spot.
I thought I already put you on the spot once. Dr. Pandian Natarajan, if you're there. No. Dr. Ravi Shankar? Okay, so if any of you come up with more questions, we still have about 10 to 15 minutes. So before that, Radhakrishna, we'll take your comments now.
Yeah. Very interesting talk, I should say, and informative. But having said that, I'm a surgeon, and most of the talk is anesthesia related, stupidity in anesthesia and anesthetic techniques, whatever. I'm wondering whether, surgeons are more stupid or anesthetists. And you all have to have a very truthful answer to it. And, I was just having a word with Vidya this morning that you people are silent spectators to whatever good and whatever bad that happens in the OT, and you just maintain the same temperament. There should be something like a stupidity score for everyone, and like Sybil score or Apache score, where, for a surgeon, only anesthetist can mark the score and keep to herself or himself, because you people have seen different surgeons. You all can categorize, can give marks. It's very easy. I think at your fingertips, but the surgeons never get to know what their scores are. Never, ever. And again, and when surgeon is come and waiting for the patient to be anesthetized, or no, there's some delay. If the spinal is not happening, he immediately will respond. He says, call your boss or something. Likewise, the patient is bucking. See, but then when something is happening in the foot end, the anesthetists are silently, they're carrying on with their work. I don't know how many ever times you get in and said, call for help, or why don't you allow somebody else, or change sides, or use this instrument? Nothing. You are allowing all the stupidity to happen right in front of you. You say you're a wingman. Wingman to whom? I mean, seriously, stupidity plays in the OT every day, and you're witness to it, and you're mute witness. because the hierarchy is such in surgery that the juniors are never going to say that. For that matter, I'll tell you, whatever happens with me or my surgery, my assistants are never going to talk to me. And even I think I've done a great job when they may talk among themselves. That's a very sad thing indeed. Actually, that's where somebody should show a torch and say, this is, I don't know whether such a thing can ever happen. It may happen in the public sector, but private sector doesn't seem to happen. I don't know if the friendship may be lost, but only you anesthesiologists can voice your opinion, because every surgeons have to evolve, because not everybody is in many times, not just many times, almost every day people would like to do something outside their circle of competence. Always. You can make out that. And my boss used to say you should always do a little more than what you have done before. Otherwise, you know where you can draw the line. You should be steered. And regarding circular competence, we're discussing quite often about doing a topic on live operative surgery, where surgeons operate in very unnatural, unaccustomed circumstances. And, that's a very terrible thing. I think anesthesia, quite often, whatever that particular hospital, anesthetists generally don't give anesthesia in different hospitals, but surgeons do it. It's a very, very difficult, I think, where people are out of their arena and get into all sorts of trouble. So my point again is, the anesthetists have got a huge role. You should put up what is called a stupidity score that you can have among yourselves, but definitely you should have a thing on surgeons, because you are the best judges ever. I mean, Vidya is saying that, if you give time, a couple of years, surgeons improve. Giving time is, you're giving time to patients. What about the patients when the surgeon is in initial years of practice? Aren't we giving him poor service? And you're mute witness, Vidya?
No, I will just tell to just link all that you have said to today's talk, like L time. Am I right, Murali?
Yes, ma'am. Yes, ma'am.
Yeah. So L time for anesthesiologists is very short. When something goes wrong, the chance of it descending into chaos is very, very short. Fortunately, for most surgeries, the L time for a surgeon doing something and things going to chaos is long. So that is why we are functioning in that borderline tolerant condition we allow, because we know we are outside that, but we are tolerating it because there is time. But coming back to serious things, I think most of us, at least the senior anesthesiologists or those who are trained under what should I say, watchful anesthesiologists. Like Ram said, we were lucky to be trained in JIPMA, where the anesthesia, Dr. Ravi Shankar, Dr. Kangle, everybody used to watch the surgery. Like, we are trained to be there and watch the surgery. So we know when something is going wrong, and we have watched enough surgeries to know the steps or whatever. Or even, I even go ahead and ask, like, what is that or what is this, if I'm not familiar. So we do open our mouths because we are actually watching. So we can only say when something is going wrong when we are actually there and watching. So definitely I have been instrumental in getting a call for help, or telling the senior that I think, it's not going right, you please come and take over. Yes, as a clan, I think we are more tolerant, and surgeons are quite intolerant. Even a simple thing like putting a trocar into the abdominal wall, I think definitely requires much less skill than getting a spinal where you are blind. But the surgeon will be intolerant of a junior who can't get the spinal in first shot. But if they are struggling 5 times poking to get into the thing, they'll say, oh, you know what, this is a fat lady, this relaxation not all right, or something. It's never their fault. So those things and all we have got used to, which is not right, like you said. What about the poor patient? Yes, I agree. But most of us do speak up. I don't think we allow patient harm to happen in front of us, in front of our eyes. Somebody else can,
It's not just, see, decision to operate, unинdicated surgeries, unинdicated LSCs, unindicated this, negative appendectomies routinely happening, sort of not so ethical judgments. These are all the things only you can say. Man, you should be the real wingman, Vidya. I'll not mind if you. But I often wonder, over a period of say 12 hours, and the OT, you see a lot of surgical stupidity and you keep quiet.
No, I don't. That's why I don't get the popularity medal.
I maybe Dr. Murali keeps quiet. I don't know.
No. Okay, Dr. Murali, you can just respond to that. So many comments that Radhakrishna made.
Definitely in the next talk when I give, I'll include sir's name with stupidity score. So hopefully that is something. That is something. But sir, as you mentioned, yes, we tend to see a lot of variability in the competence of surgeons during our career. But as ma'am was saying, we do voice it up, especially when it is patient safety. So when there is something which is really truly going wrong, we voice it up, make sure that a senior surgeon or somebody else who knows what is to be done is there, or who arrives quick enough to kind of salvage the situation. So I think not many people will silently watch what is happening, because at the end of the day, the patient is theirs and they would want the best to be done for the patient. So I think the culture is changing, especially with the youngsters nowadays. Youngsters do voice themselves out very well. So I think going ahead in the future, I don't think we'll see much of silent spectators, anesthetists being silent spectators.
And not only the anesthetists, even the nurses on the floor now, at least in our place, we've made it, for want of a better word, empowered. I mean, who am I to give power? But nevertheless, that word is used. So I'm saying we have really empowered everyone to, open their mouth and speak when something is going wrong, irrespective of who's the person doing the error, either by oversight or because of stupidity, whichever way. So,
Vidya, regarding the Venkatesh's question on a catheter causing injury, I think, it's the surgeon who has to respond. And I think one has to be truthful and sit and explain that such a thing has happened and it's unfortunate. But if you try to hide that, to cover it up, you have to tell so many more lies. I think, I don't know how many will agree with that.
Let me respond to that, sir. What happened exactly? The surgeon and the senior surgeon, he came, he said this is exactly what happened during shifting. It got stuck in the trolley's wheel and it got pulled, and it was nobody's fault. It happened. And the family didn't take it well at all. That was expected. And being honest is very difficult sometimes. But then the family raised hell, they shouted, and everything was done. Fortunately, in a couple of days, it settled. We put in a catheter and everything got settled. And there was no significant injury. But they left the hospital without paying a penny.
Yeah, that's okay. Yeah, but that's a price you pay. But then at least everybody spoke the truth. They all sleep happily. This is likely to happen. Now, for that matter, for a surgical patient, it's an anesthetic event which can lead to some serious thing. Actually, a surgeon has to respond. You can't say, I haven't put the knife, I'm not responsible. I know there are many occasions where I have to face. There's no communication between the anesthetist and the surgeon, between the surgeon and the patient. The business is between these two only, by and large. So, you can't say that it is not my area. I didn't put the knife, so I'm not responsible. Dr. Murali, you agree on that?
Yes, sir, I agree.
Actually, sometimes it's quite the opposite. When a patient who's been operated on, where post-operatively develop some complications, sometimes, almost always, if I am involved in that patient care, then I find it better that I go along and talk, because people tend to, if there are two other, let's say a surgeon and a gynecologist, you can see that both of them are talking different things and all that. So sometimes it's better that somebody who's not the operating surgeon actually tells about what happened. So I have been a party to many of these communications where then they take it from me as truth, because I'm the within course neutral observer. Let's assume it was a surgical problem. So if I tell, then they sort of take it better. So
I'm surprised, Vidya. I mean, it's very heartening to know that you get involved, but I haven't seen in so many years in the post-operative period whether ever any problem happened, the anesthesiologist came and spoke. Actually, it's not their area to come and speak at all. But if that is so, there's nothing like it. You know, you're an exception, I should say.
so main thing is we plan to make sure that everyone knows what they are going to talk, and don't talk at cross purposes in front of the patient. So that is more important. So KK, though you're not neither anesthetist nor surgeon, but you also work in a complex environment like a cath lab. So your comments on this whole thing.
Yeah, I agree. I think in the cath lab environment is identical, and I have devised a 25-item checklist for my own cath lab, and I teach that a lot, and integrate that with mindfulness. All the principles apply. Everything that has been laid out today applies to the cath lab in every single possible way. And I'm sure it applies to many similar environments where we work. And all these principles of communication, when things go wrong, exactly the same thing. And but I found this whole process of having anesthetists. I mean, I think Dr. Radhakrishnan is very, very open about to criticisms, but in the real world, that's a big challenge, and that's a very touchy point I've noticed out there. Anesthetists finds it very hard to be critical, but they have their own, grapevine and their network, and if you can tap into that, you'll get a very clear idea as to who's competent and who's not.
So, like, they will ask us whom to get operated by. So I think we need to be more vocal about that. I totally agree. Sometimes you don't even have to talk about somebody. You can talk to that person directly, and most people are quite what should I say? If you're not criticizing and you're trying to help out, even the senior most surgeons are actually quite open to listening to the anesthesiologist. So when I started my career, I worked with Professor Venkateswamy, who's a pioneer of microsurgery and free tissue transfer and toe transfer and all in India. I was just like wet behind my ears, like about just starting my career. But after a while, after any cosmetic procedure, he'll tell me, "Oh, Vidya, you have a look and tell me if it's all right." Or if I say that something this doesn't seem okay, they will actually change the what they were doing, or some orthopedician is fixing a fracture and some screw seems off. If I say that is that really okay, then obviously you should know how to put your points without being critical or this thing. I mean, offensive. But I think most people are actually open to suggestions, or they know that you are worried about the final outcome as much as them. So it's not like, okay, I have given the spinal, my patient is fine, so anesthesia is going fine, so it's not my problem if the joint gets screwed up or something. If they know that's not the attitude. So yeah. So if anyone else has any comments, please put your hand up or type it on the chat box. We are kind of almost out of time. Let me just quickly look at all the other comments that came. Everyone is just absolute agreement with you. And yeah, like KK says, most systems don't permit truthful expression. I mean, it comes at a price. So if you're willing to pay the price, you can be truthful. That's what I would say. And like Murali said, the stupidity score is going to be the catchphrase after this. And Namrata has mentioned about the MDT. So like KK mentioned, not sometimes talking in a group is good. Sometimes one-to-one is better. So yeah, I was part of those multidisciplinary meetings when we try to update patients' relatives about some patient who's not doing that well or has been in hospital for too long. Yeah, I think we're kind of done. So your closing comments, Murali?
It's been a wonderful 1.5 hours. I mean to say, there's so much of wisdom that I have also gained with so many senior people here. And I'm taking a few points from the entire discussion so that it will kind of, I can add it to my next presentation or even teach the juniors. So thanks a lot for the wonderful opportunity. And Dr. KK, thank you for moderating and giving your wonderful insights. Thank you.
Thank you, KK, for sparing a time. I know you're awfully busy. Your closing comments, please.
No, I think it's a privilege to have been here, and I absolutely learned a huge amount. And if you're primed, you're speaking to an enlightened audience here. Anybody who joins Marvelous Medicine is really in search of newer vistas and is open to a lot of ideas from everywhere. So this is a very elite group, and it's a real privilege. And I just sometimes regret the fact that I'm not able to come and join every single talk that you put together here. Is very insightful and educative, and it potentially can change all of us in a very positive way. So again, Murali, it's a great talk. I suggest I have written two names of two books, by Rolf Dobelli.
Yeah.
Applies to a whole lot of, these are all cognitive biases that we live with.
Yeah.
Both the books are terrific, but it's time you write one. Huh?
I've written one, sir. I've written one.
So you must read Think Like an Anesthetist, a book that you must read, KK.
Yeah. I saw that. So perfect. I mean, if these the messages from this talk are articulated in that book, that's fantastic. If they aren't, then write another one.
Sure. Thank you, sir.
So thank you everybody for logging in and such an interactive session. We'll meet again next week with our monthly episode of Beyond Medicine, which incidentally is going to be with a multifaceted anesthetist, Dr. Jayachandran, who's an anesthesiologist, administrator, violinist, movie maker. I think he's into quality. I don't know, so many things. So Radhakrishna, as you all know, is very good at getting the best out of people and making them say things that they never intended to. So we hope you all join us next week at 8 o'clock. Till then, take care and stay safe. Good night.
Good night.